Thank you for the invitation. I just moved to Dallas a few weeks ago, 5 weeks ago to be exact, and I came from Ghana, where I had spent 2 months doing adult and pediatric scoliosis surgeries, mostly pediatric deformities. It was really a very impactful 2 months, probably the most impactful time of my training. And I'll share a few of those experiences with you, but also give you a sense of how you think about performing these complex operations, whether it's vascular surgery or otolaryngology or different type of oncologic operations, how you can do this in the developing world. Let's see. Here we go. So I am from Nigeria. I was born in Nigeria. I was in military school there when we left when I was 12 years old. So I spent 2 years in military school between the age of 10 and 12, and we moved from Nigeria to Trinidad and Tobago. And Trinidad and Tobago is a small island just northeast of Venezuela, and they're known for their rum. So if you're a rum drinker, look up the rum from Trinidad and Tobago. But when I got to Trinidad and Tobago, something interesting happened. I became fond of soccer. So I started playing soccer. I had coaches who would teach me soccer. And I saw manicured lawns for the first time in my life. I'd never seen that in Nigeria growing up, so I started playing. And when I was 18, I earned a scholarship to Duke University in North Carolina. So I was a varsity athlete there for a couple of years. And while I was there, I was introduced to Alan Friedman, who was the chair of neurosurgery at Duke, and really got me interested not only in neurological surgery, but also in global health. Mike Haglund was in the Department of Neurosurgery at the time, and he had a big mission in Uganda. And so my goal was to build hospitals. I wanted to go back to Nigeria and build hospitals. I remember, getting malaria and typhoid fever, and I remember the, heroic staff who took care of us when I was back home. And so my goal was to do that. So I left Duke, I went to Vanderbilt for residency, and I returned to Duke. And then I went to Washington University in St. Louis. And at the end of my training, I decided to go back to Ghana. And I wanted to go to Ghana because I really wanted to understand firsthand what it was like to provide care in a resource-limited climate. Okay? Anybody know who this is? Who is this? Correct. So this is Jim Kim. So he's a very interesting man. He is the first physician who is the president of the World Bank. So he was appointed between 2012 and 2019, and he is an infectious disease specialist. Okay, and he was part of the Harvard system and left to go to Dartmouth. He worked with Paul Farmer in Haiti and all this stuff, and then left to go to Dartmouth where he was the president, and then Barack Obama nominated him for the World Bank. I met him in 2017 when he came to the American Association of Neurological Surgery meeting. And at that time, he shared his vision about the world, about global health, and so on. But in 2014, he did something that no other World Bank president had ever done. And he sort of gave us this shared vision of surgical equity, global surgical equity. And he challenged, almost really a call to action for global surgical equity and a strategy to develop global surgery in developing countries. And at that time, that was interesting because it was the tail end of the Millennium Development Goals, and we were sort of transitioning to the Sustainable Development Goals. So we really had a lot of nation states and federal governments that were very interested and really had made a commitment towards universal coverage. And his push was, we need to include surgery in whatever national coverage you had because it was an indivisible and indispensable part of healthcare. So because of his push came the Lancet Commission. And the Lancet Commission, of a lot of the work you've seen in global surgery and the push for global surgery came as a result of the work done by the Lancet Commission. So they had 3 chairs, they had 25 commissioners, and they had collaborators from 110 to 120 countries. And they were tasked with figuring out what did the landscape look like for healthcare in low and middle-income countries, what were the challenges, can we come up with strategies to address these challenges? And can we do that by the year 2030? So a very ambitious timeline. And they did. They came up with several suggestions, some of which I'll share with you today. But what became very evident was that we were very successful at managing infectious disease. That we had, the mortality rates were lower, the disability adjusted life years were lower. We had tremendous gains from managing infectious disease and lifestyle illnesses, but we had neglected surgery. And up to 30% of the global burden of disease were things that were amenable to surgery. And we had completely neglected surgery. And so this became, as they did more digging and got more information, it became evident that you couldn't meet those sustainable development goals if you didn't have a strategy for essential surgical care in low and middle income countries. And so they came up with this. And if you remember anything from this talk, this is one of the slides I want you to remember. Over half the world's people have no access to surgical care. And access was defined broadly as, are they within 2 hours of a hospital or a facility that can provide surgical care? And the number 2 came from, it takes about 2 hours from a complication from birth until someone dies. Okay, that's where that 2 hours came from. Do they have the capacity? So if you get to those facilities, do they have the capacity to take care of you? Okay, is it safe? If you have to go through a war zone to get to a hospital, that's probably suboptimal. Okay, and is it affordable? Billions and billions and billions of people, some have access to care, but they can't afford it. The median income in low income countries is about $1 per day. How do you pay $30 or $40 for an X-ray or a CT scan or an MRI? How do you pay $700 for a minor procedure? And how do you pay $10,000 for a neurosurgical procedure? It's not going to happen. And based on those numbers, they estimated that 143 million procedures need to be performed in addition to what we currently do in order to meet this unmet need. I'll give you some context with this number. Globally today, we perform about 330 million operations across the globe. So this is a huge, huge increase. It's a 50% increase. And we're not talking about high-income countries. We're talking about low and middle-income countries. How do you do this? How do you do this in a way that's reasonable? Countries that are strapped financially, they don't have the human capital, they haven't got the infrastructure. And in order to do that, to perform this minimum number of operations, you need to at least train 2.2 million general surgeons, anesthesiologists, and obstetricians. So you have to be able to provide, any facility should be prepared to provide one of 3 things. Open laparotomies, take care of orthopedic trauma, and basic obstetrics and gynecological care, okay? And they estimated that if you perform about 5,000 surgeries per 100,000 people, that was the very bare minimum, and you get to this number. To give you some context, in the United States, it's 28,000 operations per 100,000 people, just to give you some context. So it's expensive. This was the cost, $420 billion for low and middle income countries over 15 years to scale up to be able to perform 150 million additional surgeries. But if you put this number in context, then it makes sense. In 2017, the gross world product was $80 trillion, just 2017. The investment needed over 15 years is 420 million. So just a fraction of the gross world product. But you still have to convince central bankers and ministers of finance that this is worth investing in, okay? And this is one of 2 graphs that sort of convinced the central bankers that there might be something to this story, okay? This looks at the total potential loss from the labor force, lost disability, to low and middle income countries by 2030. And the estimate was it loses as much as $12 trillion over a 15-year period if we don't at least begin to take care of these surgically amenable diseases. $12 trillion. That's a big number. And what was interesting when I saw this graph the first time was injury and neoplasm accounted for most of the loss. So if you're in any country in the world, the people more likely to get injured from car accidents and motorbike accidents are young people, 16 to 30. So they're in colleges, they're in universities, they're getting the skills necessary to enter the workforce, and they're incapacitated. You're 55, you have that up spike and uptake in oncologic problems, so the more experienced members of the workforce are also being lost because they have no access to surgical care. We know that 60% of surgeries of oncologic care can be controlled, at least, with surgery. So you're losing young folks coming in, you're losing some of the established folks. And this is important because 16 million people every year in low and middle income countries are lost to illnesses and injuries that are surgically amenable. 16 million. And the estimate is that if you can create systems that work, 77 disability adjusted life years can be averted if you create and if you can meet this surgical need. And this is another graph, and this graph is one that most central bankers would appreciate. This is one that President Kim presented in 2017 when I met him for the first time. And it's a graph that comes up over and over again. The average annual growth, GDP growth, estimated for most countries is from 1 to 4%. 4% you're doing really well. In China, you're 6%. Most countries are hovering between 1 and 3%. It turns out that just because of surgically amenable disease, the lack of essential surgical care, that these countries can lose up to 2% annually in GDP growth every year from the lost productivity, from death, and from the loss of individuals and human capacity in the labor market. That's a big number. It really stunts them economically. And these are the types of arguments that were made to get central bankers, to get federal governments in low and middle income countries interested. Prior to these numbers, I'll tell you, a country like Nigeria, we had less than 1% of our budget was dedicated towards healthcare. After some of these numbers came up, it went up. And central bankers start competing with themselves about the percentage of their budget that is dedicated to healthcare. So what about neurosurgery? How well have we done in neurosurgery? Well, here are some of the numbers. You need about one neurosurgeon per 250,000 people, okay? In most low-income and middle-income countries, you have one neurosurgeon per, what did I just get? Oh, here we go. They have one neurosurgeon per 10 million. 6% of neurosurgeons, this is a very, very, very conservative estimate, take care of 34% of the world's neurosurgical population. 40,000 new cases of hydrocephalus. Now, hydrocephalus means that you have excess fluid in the brain, okay? If treated, it's a benign problem. Untreated, you have cognitive deficits, you can potentially die, there are other deficits you can have as a result of it. It can be absolutely disabling. You're not doing a very good job. TBI, traumatic brain injury, traumatic injuries in general. 50% of the cases of loss of disability in low and middle income countries are from trauma. And annually we estimate that 5.2 essential neurosurgical cases going in. Another very conservative estimate. So how do you provide care, complex surgical care in developing countries? And this is what really got me interested. And I have to tell you, this is a zoomed in map of Ghana. So Nigeria is to the east, Burkina Faso is to the north. I want to tell you a story about this foundation of complex orthopedic spine surgery, orthopedic spine focus. And this was started by a gentleman who is a mentor of mine now, Ohane Babuachi. So he's a very interesting story, a very inspiring story. He came to the United States when he was 17 years old. And he enrolled in Brooklyn College in New York. And he realized very quickly New York was very expensive. So he had a side gig as a security guard. And he was a security guard at Cornell. And his hope was that one day he can be a physician at Cornell. So he finishes his undergraduate education and he stays on for medical school at Columbia. And he stays on for residency in Columbia. And then he goes to the Twin Cities. And at that time, they had probably the most advanced spine deformity program in the world. So he trained there. And then he started going to Ghana. So he finishes his deformity training and he starts going to Ghana. And he finds this small one-room facility, which I had the pleasure of seeing when I went there. And he would just see patients. And he had no strategy, he had no plan. He just wanted to give back in some way. And when he went back to Columbia, to Cornell, he ended up being the director of scoliosis surgery for 25 years at Cornell, and he was the past president of the largest and oldest spine society, which is the Scoliosis Research Society. But 21 years ago, he goes back and he starts recruiting his partners. Say, let's go to Ghana. Let's go see patients in Ghana. And they'll go see patients, and patients who they deemed were surgical and they could operate at the time, they'll do the surgeries at the local hospitals. And those that they couldn't get to, they'll come back 6 months later or 8 months later. And they started going more frequently, and he started bringing more people. So 21 years ago, it really turned into an operation, like a legitimate operation. And since then, they have treated 60,000 patients, 3,100 very, very complex operations, one of which I will share with you today. They've treated patients from 53 countries, 6 continents, and they have close to 600 volunteers. It is one of the global outreach sites for the Scoliosis Research Society. They do more complex deformity surgery here than they probably do anywhere else on planet Earth. I'll show you how we did it. So I got to Ghana, and I'm amazed by the facilities. He has put together an infrastructure which is just not what you would expect for a developing country, a low-income country. In this facility, you have outpatient. You have outpatient departments. You have urgent care departments. They can triage patients. They can scan them. They can identify who needs surgery and who doesn't. Most of the work they do here is orthopedics. They're now branching out into other areas. They take care of 95% of all the labs they need on site. They don't send them anywhere. They're very complex. They might send them to the capital city, Kumasi. They have CT scanners, MRI scanners, and X-rays at the facility, all of which were donated by different countries and different institutions, with the shared commitment that every year these things are maintained, and the joint fund is created to maintain these facilities. Some of these patients come from remote areas. You can't send them for local physical therapy, so you have to provide them on site. So they have a world-class physiotherapy and physiatry team. The operating room was state-of-the-art. And they have a world-class intensive care unit managed by the anesthesiologist. 100% of the people at this facility were trained in Ghana. They were nurses that went to nursing school in Ghana. They went to medical school in Ghana. And some of them were sent abroad for a few weeks, and they leveraged technology platforms for virtual educational exchange. They went back to Ghana. So they were able to build this in Ghana with local Ghanaians, with funds from NGOs and private donors, with some commitment from the government. But it's not the classic, let's wait for the federal government to do something. And it's also not the classic, let's go to the middle of nowhere with no infrastructure and perform this type of care. They found a way to do it. They have trained nurses, so they recruit all the nurses that they can. They give them a contract for 4 years and say, come work for us for 4 years. We'll pay your tuition and go to nursing school if you commit to working for us for 4 years. They have the first orthopedic fellows in the country were trained here. General orthopedic trauma, spine, trained here. Physiatrists, they have 3 neurosurgeons that are part of their group, all trained in Ghana. Anesthesiologists. So they have a workforce that's trained in Ghana and a part of delivering this world-class care that I'll show you a case of very shortly. This is a rendition of this is a top-down view of the facility. This is the main administration office. This here is the cafeteria, and you've got some other units here. Here you have the outpatient clinics, and you also have some patient rooms here. This is where most of the rehabilitation, the patient rooms are. The operating rooms are over here. This part of the hospital hasn't been built yet. They're still raising funds to do that. What they have here is they have some solar panels, and they have solar panels and all of these buildings to cut down the electricity generation and cost of providing, the average cost of providing care. This is one of their case conferences, and that's me there. I'm giving a presentation on a patient with a thoracic herniated disc who was severely myelopathic, and we were trying to decide what to do for him. But this is one of the education conferences, and this conference occurs every day, 4 days a week, Monday through Thursday, 7 to 8 a.m. in the morning. It's attended by neurosurgeons. That's Dr. Yankee. It's a neurosurgeon. This is Dr. Ohane Babawachi, the gentleman I told you about. This is Arthur. He's one of the orthopedic spine fellows. They have an anesthesiologist right here. Her fellows are behind, so they have 20 people, if you can imagine, sitting behind the room. So they have 20 people sitting, and then the fellows and the surgeons are mostly at the table. These are nursing students who are part of the frontline staff. And we have this joint conference every day. So there is a really rich exchange of knowledge, really rich exchange of ideas between all the services involved in delivering these patients' care. The other thing that was interesting here was they log in and they are part of these they use virtual platforms to take advantage of ground rounds presentations. So while I was there, we watched a few presentations from Seattle, the University of Washington, Duke. So you didn't have to provide all the education on site. You can leverage these technology platforms, which is what they did. So I'm going to give you an example of an operation that we performed in Ghana. And if you're averse to blood, this is where you should probably step out. But the case I'm going to describe is a routine case that they see in Ghana. I trained at Washington University in St. Louis, where 40 to 60% of most of the classically trained deformity surgeons in the United States were trained. And we would see cases like this once every 2 months. And this is the case where everybody is in the operating room. We're taking multiple pictures from multiple angles. And this case, we would do 4 to 6 a week in Ghana. There is no other place on planet Earth that you'll see cases as severe with this much frequency as you see in Ghana. So she's a 13-year-old girl, and she had been there for a few months prior to my arrival. I'd known that she was there. She'd been there for a few months prior to my arrival. And she presented initially with paraparesis. No pain. She just had weakness in her legs. She had no problems breathing. She had no other issues. She had a few abrasions when she presented. That's from the traditional doctors, where they put local medicine to try to arrest the deformity. But her main complaint was a deformity, a progressively worsening deformity, and she was getting progressively weaker. She had no history of tuberculosis. She had not taken any anti-tuberculosis medication. That's a big deal in West Africa. A lot of these patients with spine deformities have tuberculosis. And she had no previous hospitalizations. So just obvious deformity, weakness in her legs. This is what she looked like. She's 13. Now, I don't know if you remember neurofibromatosis from medical school, okay? So she has some of the cutaneous malformations that you would expect with neurofibromatosis, okay? She has, usually if you look in her eyes, she'll have niche nodules, she'll have axillary freckles. She's got this huge cutaneous lesions, cafe au lait spots that you might think about, okay? And they also, in neurofibromatosis, you might have some neurofibromas, you could also have some deformity. She's 13, undernourished, unable to walk. You can't see the abrasions very clearly here, but she had several abrasions of her skin. That's not uncommon to see in these patients because if you had a spinal deformity, the traditional doctors would typically think that they can treat that. And so they put herbal medicines and it doesn't work. Not surprising. This is what she looks like, the sagittal profile. So you don't have to be a spinal surgeon to know that it shouldn't look like that. She has these massive cafe au lait spots, severely undernourished, and she's 13. This is what her spine looks like. Let me describe what you're looking at. This is an AP view, and this is a sagittal view of the X-ray. Okay? Normal curvatures of the spine should be anywhere from 40 to 60 degrees. You were not made to have curvatures of 240 degrees and above. This is the top of the spine. You can see here mid-thoracic going up. You can see here straight coming up here. But what you notice here is a horizontal segment in the spine. So she has a horizontal segment in her spine. This is a complicated operation to plan for. You can begin to think about how you strategize managing a patient like this. But there are strategies and algorithms we have that we can go through. This is what the CT rendition looks like. Cases like this, you don't see very much in high-income countries. You don't see very much because if they have this problem, they catch it very early. They don't get to 13 years old. And we saw numerous cases like this. TB, NF1, sharp, angular, bad deformities. This is the inferior aspect of her spine. That's the superior aspect of her spine. That's the horizontal segment. The spinal canal was supposed to be perpendicular to the ground, not parallel to the ground. It was a very bad deformity. The first thing you have to do in a case like this is try to unwind the spine. So you put them in traction, halo gravity traction to unwind the spine. And that technique we learned from Hippocrates. He was the first one to coin scoliosis, when you notice an abnormality in the spine. And they would try to stretch these patients to unwind the spine. That's what we still do. So we were having a discussion today over dinner. The more things change, the more they remain the same. This is what the CT scan looks like. This is that horizontal segment of her spine. If you try to attempt this operation without unwinding the spine, there's a 50-60% chance of paralysis. Most hospitals in the country, in the United States, can't deal with this. Most hospitals in the world can't manage this problem. And they saw numerous of these cases every week. 6 to 8 of these cases. This is a picture of her hand. I just showed this here to show that she's still growing. So if you did nothing with the deformity, it will get worse. This is what she looks like. So this is what the traction device looks like. You fixate it to the skull. They live, sleep, go to school in this. All of this is at that center. So they have teachers at this center that teach them. They go to rest, they eat, they go to sleep in traction. The goal is to unwind the spine. And this is 4 weeks after traction, and we just haven't made a whole lot of progress. Okay? This is her sagittal x-rays 4 weeks after traction. Not a whole lot of progress. And this is pre-op, 4 weeks, 8 weeks, 16 weeks. What you'd like to see is a 30% improvement from the baseline number. That tells you that the spine is flexible enough. When you go into the operating room, you don't have to do any vertebral column resections. And that was what you were referring to earlier, removing that bone. In a straight spine, it's dangerous. In a curved spine, it's astronomically dangerous. This is her 4 weeks after traction, 240 to 239, no progress, 236, 227. So she needs a very complex operation. And this is the CT reconstruction after traction. She hasn't moved. This is where I'm going to show you some intra-op pictures. So if any of you are averse to blood, this is where you close your eyes. And this is what the intra-op photographs look like. For some of you who have been in operating rooms with spine deformity surgeons, let me explain what you're dealing with here. The head is over here, the bottom is over there. This is the spinal cord. Okay? That's the spinal cord. The bones behind have been removed. We've removed the bones in front, so complete vertebrectomy. These rods stabilize the spine because the spine is 100% unstable once you remove everything circumferentially. And then you begin the reduction process. You begin to reduce and realign the spine in sequential ways. This is another view of the spinal cord. That's the spinal cord there. That's the hole that we've created to remove the vertebral bodies. Okay? And this is us going through the correction maneuvers to reconstruct the spine. This is what it looks like. The spinal cord is buckled. You can see that there. Fecal sac is buckled, but it looks straight to me. We finished the operation. The bone grafting has been applied, and her spine is straight. So she had a T10, T11, two-level vertebrectomy. Took close to eight hours or so by the time she got out of the operating room. Her motor evoked potentials and sensory evoked potentials never changed. She had cell saver. She had 2 liters of blood loss. She had implants that were made in China. Every person in this operating room, with the exception of myself and Ohane Babawachi, were trained in Ghana. So when you think about global health and you think about using and sharing your skills, you have to build it and do it in a sustainable way. The implants they use were a fraction of the cost of the implants you use here. They were cheap, built, made in China. The anesthesiologist came up with creative ways to recycle blood during the surgery. The nurses who performed the motor evoked potentials were nurses fresh out of nursing school. They sent them to New York to learn a few things at Cornell and brought them back. And they did the rest of their courses virtually from Ghana. An impressive operation for a local, entirely trained Ghanaian staff. This is what the x-rays look like after surgery. And this is what her sagittal profile looks like after surgery. If you live in a high-income country and you have a deformity, it's bad, it's a big deal. If you live in a low-income country and you have a deformity and are unable to walk, it's a death sentence. There are no off-ramps. There are no programs for you. It's just bad luck. So you're changing people's lives. And when you do 4,000 of these operations, more than anywhere else on planet Earth, you're really making a huge difference. But more important than the surgeries and the staff he has assembled, the nursing staff, the anesthesiologists, the physiatrists, they go back to their communities and they're frontline of their communities. They're able to detect and triage simple medical problems and sort of steer those patients to seek appropriate care. So how do you provide quality care, surgical care, in a developing country? What do you need? Well, first, you need to think about having facilities that are prepared to deliver them. You need to think about facilities that deliver them and how you're going to measure that metric. And you need to think about financial protection, measuring the impact of that. So when you think about access to timely surgery, if you just gave birth and you have to ride a donkey 18 hours because you have a hemorrhage, you're not going to make it. If you have an orthopedic fracture and you show up in a hospital where there's no surgeon, there's no anesthesiologist, there's no medical provider, you have a disability that can easily be prevented. Okay? If you have a neurosurgical head bleed, subdural hematoma or epidural hematoma, and you show up at a hospital where there is no capacity, you're not going to make it. So when you think about access to timely care, it's not just having the facilities that matter, they have to be accessible in a timely fashion. And 2 hours was that threshold that they identified. That's the threshold for epidural hematomas. If you can address it within a few hours, you do okay. For complication from delivery, you can address it within 2 hours, you usually do okay. It needs to be affordable. They have to be able to afford it. The median income is $1 in most of these countries. How do you design and think about performing some of your complex surgeries in these countries? You have to have the capacity. You have to have staff. It's not just putting up a building. You have to have physicians, surgeons, you have to have nursing care, security guards, and so on. And it has to be safe. Most of these low-income countries are in war zones. You can't build a hospital where they have to walk through a conflict zone to get care. So these are real challenges that you have to think about as you start thinking about and cultivating your interest in rural health. Workforce density. If you have to provide 150 million additional surgeries, how many people do you need? We said 220 million, 2.2 million, sorry. That's about 20 per 100,000 of any combination. Surgeons, obstetrics and gynecologists, and anesthesiologists. So you have to have a capacity within that country to train 20 per 100,000. What about surgical volume? Now you have the staff, now it's safe, maybe affordable. You have to be able to perform about 5,000 operations per 100,000 patients. When I was a junior resident at Duke, my first year, Duke would go to Uganda. And the champion of that program was Michael Hagland. And when they started the program, they had an operating room, but it would only do 50 to 60 cases a year. How do you build the capacity, keep them prepared, and deliver quality care over and over? These are real challenges that people have to think about. Then how do you measure your outcomes? It's what we were talking about earlier. You go, you're altruistic, you do an operation in a developing country, you do a craniotomy, you remove a brain tumor, and you hand the baby over to the mom. And she dies in the middle of the night. That's not quality care. You do a big abdominal operation, and you hand the kid or the person back to their family members. You feel good, you've gone to a developing country, you've spent 10 days, you've taken lots of pictures, you've done lots of cool operations, but the patient didn't survive. So it's a failed mission. It's a failed mission. How do you measure outcomes? We should be able to know the percentage of patients who die after surgeries. It's a no-brainer. In the United States, in England, in Western Europe, in Australia, if you have an operation, we could tell you your mortality rate. We could tell you how many people die within 30 days and how many die within 90 days. Why is it different in Guatemala? We should know that. So you can't build a sustainable system if you don't have these numbers. What about financial protection? How many of you have gone to the emergency department here? You show up, they take care of you, maybe they scan your insurance card, they get all the scans you need, they draw some blood, and at some point you get a bill. And maybe the insurance companies pay some, but we still complain about the co-pays, even if it's like 10 bucks. We're still complaining, right? When you go to these countries, you have an injury, you show up at the emergency department, you get in line. You have one hospital that was built 80 years ago for 150 patients, and they have 1,000 patients in the hospital. There are no imaging modalities, no x-rays, no CT, no MRI. You're not gonna see a surgeon. You may be lucky if you see a nurse. You're lucky if you get antibiotics or pain medications. And maybe you get a bandage around that fractured, exposed bone, and they figure it out. And if you have money, you pay, and the surgeon says, if you pay me, I might take care of this tomorrow. But you pay for everything. You pay the anesthesiologist fee separately, you pay for the surgeon separately, you pay for your health care separately. For each and every provider, you pay separately. Even the people who can afford it, it's financial ruin. Most people in these countries have not a whole lot. So when you ask a family unprepared for 10,000 US dollars, it's not affordable. So when you build systems in developing countries to provide care, and when you think about universal healthcare platforms in these countries, it's not only for infectious disease, it's not only for HIV and tuberculosis. We should build in for surgical care and anesthesia care. That should be part of the discussion at all points. Billions of people experience financial ruin as a result of paying for or trying to pay for services for healthcare, for surgical services. So what are the practical realities? So you read the Lancet report, juiced up, we're going to change the world. What are the real practical realities? You go to your Minister of Finance and you say, hey, I figured it out. We lose 2% of our GDP if we don't take care of patients, if we don't provide essential surgical care. And he tells you, well, that's $20 billion a year. Or maybe that's $2 billion a year. We have to pay for defense, we have to pay for schools, we have to build financial infrastructure, we have to build roads. We don't have money, we don't have $2 billion. I mean, the entire GDP is 1.7 billion. The reality is you cannot have a successful healthcare mission in isolation. It has to be part of, as the economy grows and the more successful the country becomes, the more money they have to spend on healthcare. That's the reality. Infrastructure. So you finally get the money and you build a hospital. Get some land in a remote part and you build a hospital, but there are no roads. There's no road to get to your hospital. The government has no money to build a road to get to your hospital. And any of you who have volunteered in, gone on mission trips, gone abroad, this is a reality. You go in a remote part of the country and there's no access. There's no way to get there. There are no roads. So finally they build a road, but there's no electricity. When I go home, I flip on the switch. It's automatic. It's like oxygen. Light comes on. In some of these low middle income countries, you might get an hour of electricity a day, an hour a week. How do you factor that in? That's the reality on the ground. That's the real practical reality of delivering care in these climates. Okay? No water. That's real. Human capital. You have medical schools where faculty have been on strike for years and graduated a medical student in 2 or 3 years. You have the money, you build a road, you have electricity, you have water. Where are you going to get the people? Where are they going to come from? You don't have the human capital. You don't have nurses that are readily available, well-trained, sending you CVs to get a job. It doesn't exist. You have to train them. It takes time. So these are some of the practical realities you think about. And then technology gaps. I went to Kuala Lumpur when I was in Ghana. Kuala Lumpur was a hospital built by the British, okay, built in the 1940s. It's built for 150 people, and 80 years later, is 1,000 to 1,200 patients in that hospital. And they've added in a piecemeal fashion, so you can imagine like an Egyptian rug market. Okay? You have CT scanners there, they don't work. Small glitches, but you have no technicians locally that can fix them. MRI scanners that were donated, they don't work. X-rays don't work. Anesthesia platforms don't work. So when you think about technology solutions to some of the common problems we have here, if the CT scanner goes down at UT, it's fixed before we even know it. They don't have the expertise. So you have the technology, you donate to the technology, there isn't a shared commitment to maintaining that technology, or the knowledge transfer to maintain the technology, and so it doesn't work. I put up this slide because all isn't lost. President Kim's vision of equity in surgical care that he laid out in 2014 triggered all of this. When I was in medical school, we had a global health institute, but it was mostly focused on infectious disease, HIV and AIDS. Now, any global health institute you have in this country, anywhere else in the world, has access to surgical care as one of the main drivers behind their mission. You have NGOs partner with private enterprise, develop strategies in low and middle income countries to deliver adequate surgical care. You have young people like you and I all volunteering our time because we see a better world. We think that access is important. We think that they also deserve adequate surgical care. Might look a little different, but they deserve it. The World Health Organization, the World Bank, ministers of finance, central bankers, everybody has gotten on board with this mission because they understand that they need adequate surgical care if they are to meet these sustainable development goals. So all isn't lost. Well, let me tell you what I learned. This is one of my last few slides. Let me tell you what I learned from Ghana and from Focus Hospital. I learned that if we were to wait for the federal government and the state governments to build these infrastructures, to build the roads, to build the hospitals, to get the MRI machines, to train the appropriate staff, we were to wait for the federal government, Focus would never have happened. It was one man, like you and I, and one woman, who decided that I am going to use my God-given talents. I'm going to go to somewhere where I think they might need them, and I'm going to start. I'm going to show up. I'll show up, and we'll figure it out. Okay? And he showed up. So he showed up, and he started taking care of patients. We recruited some friends. They went along. They raised some money, and one building at a time, they built a world-class hospital. The government decides, whoa, this thing is working. We're actually going to build a road for you guys. Okay? So they build a road. They give some money, and they are now training the next generation of orthopedic surgeons, nurses, anesthesiologists, physiatrists, because one person showed up. I can't wait. So I love the World Bank's ideas, but you can't wait for federal governments to figure it out, to jump in. Investment in institutions of higher learning. This is where the federal governments can play a big role. You need to train physicians, you need to train nurses, you need to train dentists. You need to have a capable labor force that can begin to address some of these challenges. You need to have a capable labor force that can begin to address some of these challenges. It doesn't help if we all have good ideas, but there's no human capital. So they need schools of higher education where they inspire the next generation to build a different Ghana, a different Nigeria, or a different country, whatever country you can envision. Leveraging technology. We don't need all the bells and whistles that you have in hospitals here. I think there should be an emphasis on technology for low and middle income countries, on development of technology for low and middle income countries. I don't need a $2 million microscope to resect a brain tumor. I just need something that enlarges my view. That's it. There's a business case for this because if you build it, you have a lot of consumers. You have a lot of consumers. And not only build the technology, but also train local technicians and have programs where local technicians in all of these countries, whether it's in Africa or in South America or Southeast Asia, wherever in the world you are, can repair them so they are usable They have some value. National health insurance. One of the things you realize in some of these countries, it's a fee-for-service model. You pay, we take care of you if you're lucky, the capacity exists, otherwise you're out of luck. And I think as they start thinking about national health insurance schemes, it has to be a pooled risk. It has to be a shared risk. That's the only way it can work. Such that when the federal public hospitals aren't working, the private hospitals will still accept some of that money to take care of the patients. There is no mission without a margin. They need to think and build that in. And lastly and finally, infrastructure development. Understanding that you need security, you need adequate electricity, you need water, and you need to be creative in how you come up with this infrastructure. What they did at Focus, but they had solar panels. They raised money and they had solar panels, so they cut the electricity bill by 80%. They were able to find wells and pump water into tanks so they could have 24/7 water supply. So you need to be creative as you start thinking about global health programs. And these are some of the challenges that you might face. And these are some of the lessons that I learned. If you're willing to jump in and think about creativity, very creative programs, that you can have a successful program. These kids all had spinal deformities. These are the same kids over here. Real changes are happening. Real changes to human life is happening. We're addressing and mitigating the surgical disease burden, and everybody has a role to play. So when I came to UT Southwestern, part of the reason I came here was their commitment to global health. It is a non-negotiable part of my career. I cannot, in good conscience, sit in an office when I know that there's somebody somewhere across the globe, or even in a rural part of Texas, that can benefit from our services. So we are starting discussions with Focus Hospital to build and cultivate a more solid relationship. I'm planning on returning to Ghana later on this year, and I plan on going every year. We're trying to build collaborations in Ethiopia, where we can go every year, take residents and fellows, nursing staff, physiatrists, anesthesiologists, orthopedic and neurosurgeons. We are fortunate that we have a combined spine center with all of these moving parts all in one place. So orthopedics, neurosurgery, physiatry, and anesthesiology. And I bet you that any of those residents and fellows would benefit from an experience like the one I had. And creating that opportunity where residents and medical students can go volunteer their time. It's a bi-directional, mutually beneficial relationship. You learn a lot from being in those environments. It challenges you to look within, to really understand who you are, and whether or not this is the kind of work you want to be doing. So my hope is that we can really cultivate this relationship and really truly help the world stand tall again. And that's it. Thank you for having me. Happy to take any questions.
So what are you, I'm sorry.
Go ahead.
I'm sorry, I apologize. So where would a medical student look to get more information on the logistics of a trip like this?
Yeah, we don't have, the website isn't up yet, so we'll just have to communicate by email. We have a global health program at UT Southwestern, led by Dr. Wariako. He's one of the general surgeons, and we're hoping to grow that. So my hope is that we can get some of this information online. Certainly the mission in Ethiopia, which we'll be going to in June, is to try to finalize the date. And in Ghana, it's probably going to be sometime in the fall. My hope is that we can get one consistent 10 or 20-day period every year where we go back, so you people can plan appropriately.
Can you talk about drug costs?
Yeah.
Like antibiotics and that, that's probably a big part of the budget.
It's actually not, because most of those drugs are manufactured in India. So all of those costs is significantly lower than what you would have in maybe high-income countries. It's still a cost to them, but they're significantly lower. Yeah. So I'll tell you, like one of those deformity that surgery in Ghana, that cost about $8,000. The families have no idea where these kids go. They show up with deformities. She stayed there for 16 weeks in traction. How many hospitals in the world would allow you to stay there for 16 weeks while you're getting your spine unwound? Anybody? No, doesn't happen. She goes to school there, she's fed there, she's educated there, she's in traction there, she has the surgery. And how many hospitals in the world do you think would say after surgery, stay on the facility until you're ready to go? Doesn't really happen that frequently. So they stay at this hospital until they're ready to go back home. There is no local rehab facility. There is no local skilled nursing facility. This is it. So part of what we're trying to do is raise money for the Ghana mission. My hope is to raise $40,000 or $50,000. They have a waiting list of 4,000 children. 4,000 children that need surgery. And my hope is to raise as much money as I can every year and go back over a 10-day or 20-day period and just do as many operations as we can. So, good question. You got a question?
Yeah, so my name's Armand. Thank you for coming. The presentation was excellent. I have a question on the outreach of the Focus Hospital. Like, how far where do you bring in patients from? Just Ghana or that whole region?
That entire region. You have patients from Burkina Faso, from Ivory Coast, from Nigeria, all over the African continent, from the Middle East. It's become known as the place you go for deformity surgeries, orthopedic surgeries. And so patients show up from all over the world.
How do they get there most of the time?
Some come by, some like from Ivory Coast or Nigeria. I tell you a story. It was this Nigerian kid, he was 14 years old, we took care of. They drove 16 hours across the border, dropped him at Focus, and he was in traction for a few weeks. And the day of his surgery, we needed consent. We were trying to get his consent from his father, but his father was stopped at the border. So these are some of the logistical challenges that you have to deal with. Some of these kids come from Ethiopia, from Ivory Coast, Zimbabwe, Kenya, Uganda. Dr. Boachi's group flies out to some of these countries and does local clinics, and patients who are surgical candidates, they pay for them to come. So they not only pay to bring the kids there, the kids stay there, they optimize nutritionally, they have an operation, and then they're flown back to their countries. Some governments are starting to get more involved now, and the governments actually would pay and foot the bill to have these kids come there and to optimize there and have their operations there. But every patient that shows up to Focus, if they have no money, they're still taken care of. That's why I think it's such a worthwhile mission to support. Any other questions? All right. Well, thank you all for coming.
Thank you. Is it a question? Is it a 501c3?
What's that?
Is it a 501c3? Like, do they have a U.S.?
They do.
They do?
They do.
So if you donate to them,
Right.
it's tax deductible?
And that's why it's easy.
Yeah.
Because otherwise, if you would, I don't know if you can donate to a company